Hi, I'm Liz Jalazo. I am a clinical geneticist at the University of North Carolina at Chapel Hill, but I'm also the Chief Medical Officer for the Angelman Syndrome Foundation. Thank you to the organizers of this meeting for allowing us to present this information on the genetics of Angelman syndrome. Angelman syndrome is caused by a loss of maternally inherited UBE3A on chromosome 15. The estimated prevalence of this disorder is around 1 in 12,000 to 1 in 20,000 live births, though until we have large-scale population studies, these really remain estimates, and it's unclear what the true prevalence of this disorder is. Typically, we inherit 2 copies of UBE3A, one from each parent, with expression from both mom and dad's copy in most tissues. But uniquely, UBE3A is only expressed from the maternal copy in neurons. Angelman syndrome was first described by Dr. Harry Angelman in 1965. He described 3 patients that he had who were quite unique to him. They had a stiff, characteristic jerky gait. They had absent speech. They had excessive laughter with an easily excitable demeanor, as well as seizures. About 20 years later, Dr. Ellen McGinnis identified a few children who had deletions on 15q, the long arm of chromosome 15, which were expected to have Prader-Willi syndrome, but had seizures and developmental delay, which were not characteristic for children with Prader-Willi syndrome. In 1991, we discovered the first case of a child who had uniparental disomy, meaning they had inherited both copies of chromosome 15 from their father. And then in 1993, imprinting center defects were recognized as an additional cause of Angelman syndrome. But it wasn't until 1997, almost 30 years after these 3 initial patients were described, that UBE3A was identified as the causative gene responsible for the features we come to think of with Angelman syndrome. These clinical features that are quite recognizable now are characterized by developmental delays, particularly most notable in expressive language with very limited speech and intellectual disability. Walking and motor skills are typically also delayed from early in childhood, with the average age of ambulation between 2.5 years and 6 years, so quite delayed compared to neurotypical, typically developing peers. Often the first sign and symptom that we notice with Angelman syndrome is these early feeding difficulties and reflux, which are very common and consistent among all types of Angelman syndrome. And we think that this is due to the low muscle tone, the same low muscle tone that contributes to this later walking. As children age, we notice this movement disorder and balance issues that contribute to the challenges with walking, and this unique behavioral profile with an easily excitable demeanor, a happy affect, with laughter, very social behavior, and children are often hyperactive with difficult to manage sleeping problems. Additionally, we see seizures, often from early in childhood. The typical age of onset, at least for a child with the deletion type of Angelman syndrome, is typically between 1 and 3 years of age. And the type of seizure can be pretty variable among people across the lifespan with Angelman syndrome. Some people with Angelman syndrome do have a small head size, or microcephaly, though this is not universal. And poor growth is common early in childhood and may improve later in childhood or later in life. And then finally, we often see the strabismus, or this characteristic lazy eye, which is again due to this low muscle tone. People with Angelman syndrome typically have pretty good health beyond the seizures and constipation that can be pretty common in Angelman syndrome, but the behavioral profile does persist across the lifespan. And importantly, lifespan appears to be normal in individuals with Angelman syndrome. As I alluded to before, the particular region of the genome that we are focused on for Angelman syndrome is the 15th chromosome. And as we zoom in here on the 15th chromosome, we see that it is really the proximal region of the long arm of chromosome 15 that we focus on for Angelman syndrome. It's this critical region between 15q11.2 to 13.1. Again, as we zoom closer in here on a chromosome, we see this critical region highlighted here in blue. Again, it's this, if we zoom into this coordinate, it's the long arm of chromosome 15 at 11.2 to 13.1. And this region spans about 5 to 6 million base pairs. This region is flanked by these what we call breakpoints, which are kind of fragile zones. And so as the chromosomes are crossing over and swapping genetic information, this region is more susceptible to deletion, duplication, particularly of this critical region that includes UBE3A, but also the regions, the edge regions around it, these breakpoint 1 to 2 and breakpoints 3 to 5. This is a graphic representation of the most common deletions that we see in Angelman syndrome. So we see the slightly larger class 1 deletion that encompasses breakpoint 1 to breakpoint 3, as well as the class 2 deletion that includes breakpoint 2 to breakpoint 3. There are more regions in this there are more genes in this region beyond UBE3A that are likely critical and contribute to the characteristics that we see in Angelman syndrome. There are not dramatic differences between the presentation that we see for children and adults who have class 1 deletions versus class 2 deletions. There are multiple genetic mechanisms that can lead to a diagnosis and a clinical presentation of Angelman syndrome. So to walk us through this schematic, our first set of chromosomes here is the typical complement of chromosome 15. So we have the paternal copy or the copy from dad in blue and the copy from mom in pink here. And as you see, we have delineated kind of this Angelman Prader-Willi critical region, again, in the proximal long arm of chromosome 15. Most individuals with Angelman syndrome have Angelman syndrome due to a deletion of the maternal critical region. Again, as I mentioned, this critical region is flanked by these breakpoints that are fragile regions and subject to deletion during the process of homologous recombination. And so this is a recurrent deletion that we see of this region. And again, about 70% of individuals with Angelman syndrome will have Angelman syndrome due to a deletion. And then we have a second subtype here. It's called paternal UPD or uniparental disomy. And as we can see in this graphic representation, that is where an individual has received both copies of the 15th chromosome from dad. So both copies here are blue, both copies are from dad. This functionally results in no maternal UBE3A. And as I mentioned before, Angelman syndrome is caused by a loss of maternal UBE3A. And so dad's copy is here, but unfortunately the UBE3A region, this critical region, UBE3A is silenced, and we'll get to that mechanism in a bit. But the functional consequence here is that we have no maternal UBE3A. Our third genotype is a UBE3A mutation, so just a either a small change within the UBE3A gene itself, a single nucleotide variant, or a small deletion or duplication within the gene that disrupts the function of the gene itself. This accounts for at least 10 to 15% of individuals with Angelman syndrome, though as we are doing more sequencing analysis of individuals with neurodevelopmental disorders, I suspect that we will find that perhaps UBE3A mutation accounts for potentially slightly more than 10 to 15% of individuals with Angelman syndrome. And then lastly, we see the scenario where we have a chromosome 15 from dad and a chromosome 15 from mom, but the molecular machinery that's causing dad's copy to be turned off results in mom's copy also being turned off. So that on-off switch that controls the expression of UBE3A is programmed to look more like dad's copy instead of mom's copy. Again, functionally, the end result from all of these molecular subtypes is that we don't have mom's copy of UBE3A in the CNS or in the brain. We can see some generalizations, though, of course, every child with Angelman syndrome is unique to themselves and has their own set of strengths and challenges, but we can make some generalizations based off of the genotype and the phenotype that we might expect or the clinical severity that we might expect. Typically speaking, individuals with deletions may have more growth challenges. It's more common for individuals with deletions to have seizures. Upwards of 85–90% of individuals with deletions will have seizures. More challenging motor difficulties, delayed ambulation, pigmentary differences that are owing to the ACA gene that's also in that region that contributes to pigmentation, as well as this severe profound expressive language delay. Individuals with the UPD phenotype can have a slightly milder clinical picture with less growth difficulties, less motor challenges, but can have sometimes more behavioral challenges and a slightly different behavioral picture. Individuals with UBE3A mutations demonstrate a pretty wide range of clinical severity and clinical skills. We still can see microcephaly. We certainly see seizures in 60–70% of individuals with the UBE3A mutation. We can still see delays in walking and motor challenges, but some may have more language skills, and some may have higher cognitive abilities and fine motor skills as well. And then lastly, we have individuals with the imprinting center defect. Oftentimes these individuals are mosaic, meaning that they have a mixed complement of cells that are missing UBE3A, but some who might have normal UBE3A expression. And as you might expect, oftentimes these individuals have higher abilities that they're able to demonstrate, better expressive language, sometimes seeing up to 50 to 60 to, more effective and functional expressive language. I'll touch briefly on the recurrence risks for Angelman syndrome. So, we never quote a 0% recurrence risk to subsequent pregnancies, but we know for individuals who have the deletion subtype as well as the uniparental disomy, there's a very low risk of recurrence. We still recommend maternal chromosome analysis to confirm that we don't have a complex chromosome rearrangement, but most of the time this is a random occurrence that is not at a significant risk of recurrence for subsequent pregnancies or other children. Where we can see in families who have multiple individuals with Angelman syndrome within the same family is with the UBE3A mutation subtype. So individuals with this subtype, because mom could harbor a UBE3A mutation that is on her silent paternal chromosome that was inherited from her father and silent in her, she could pass this on to a child. And we do see families with multiple children who have UBE3A mutation subtype Angelman syndrome. And the risk is up to 50% recurrence for subsequent pregnancies. This is an example of a pedigree that we might see in a family who has the UBE3A mutation. Again, we have, a grandfather up here who, passed on the UBE3A mutation to a mother. It is now silent in both of his children because it's on the copy from dad. Dad's copy is silenced in the brain. And then this mother then, unknowingly passed on that UBE3A mutation to both of her children. Again, because it was in the father here, he passed it on to a daughter who did not know that she had that because it was silent, and then passed it on to a child. So it's important to remember with this genotype that we can see this running in families and that there are additional family members that may benefit from testing. So again, regardless of the subtype, regardless of the mechanism that results in Angelman syndrome, the end result is this functional disruption of UBE3A on the maternal chromosome. And as a result, this absence of UBE3A in the CNS. So what is UBE3A? Why does it matter? Why is it such an important gene? So UBE3A encodes a ubiquitin E3 ligase. Ubiquitin ligases are a family of enzymes that are very prevalent in the body and serve the function of targeting proteins for degradation by the proteasome. This is a process that's critical for normal cellular maintenance and housekeeping. UBE3A, as such, is thought to play an important role in maintaining the balance of the protein synthesis and also degradation and the function of the synapse. Specifically, we know in the GABAergic neurons, which are the neurons that are responsible for kind of pumping the brakes in the brain and contributing those inhibitory signals, that UBE3A loss leads to these behavioral excitability of these neurons with this very characteristic EEG change that we see, as well as seizures in Angelman syndrome. So this functional consequence in individuals with Angelman syndrome, we have this lack of tonic inhibition, which results in this generalized hyperexcitability. We see seizures. Again, we see this motor dyspraxia, or this discoordination between the brain telling the body what to do and being able to execute that motor functioning. We see lack of speech, this severe to profound sleep disturbance, this psychomotor agitation, this kind of constant go, 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 go that we see, this frenetic energy. Poor motor skills and poor coordination, and then severe developmental delay. And the ultimate result is a significant disability and disease burden with a significant unmet clinical need. We also know that there's a significant diagnostic odyssey in Angelman syndrome. There's a big discrepancy between the average age of onset of symptoms versus the age of diagnosis. And this chart is demonstrating the age at early intervention, accessing those early services for physical therapy, occupational therapy, speech therapy, indicative of some sort of delay versus the time of actually receiving a molecular diagnosis. So as we see here, for a child who has the deletion subtype, they're typically entering into therapy by 10 months of age, but not receiving a diagnosis until closer to 2 to 3. This delay is even longer for individuals who have some of the milder subtypes of Angelman syndrome, particularly the imprinting center defects, where the age of diagnosis pushes out closer to 4 to 5 years old. So again, I've said this 10 times already. Angelman syndrome results from this loss of maternally derived UBE3A. But what about dad's copy of UBE3A? So what's going on with dad's copy? Why is it silenced? To be completely honest, evolutionarily, we don't entirely understand the rationale for silencing dad's copy of UBE3A, but we do know that UBE3A is a gene that is under tight regulation. And we do know now that expression of dad's copy is silenced by this UBE3A antisense transcript, which is a long non-coding RNA that results in the silencing of dad's copy. And what this has allowed us to do is think about targeting this antisense transcript as a therapeutic modality for Angelman syndrome. We have known functionally that we could turn off this UBE3A antisense transcript for more than a decade, but it wasn't until 2 to 3 years ago that we saw first in human potentially disease-modifying treatments with antisense oligonucleotides that are targeting disrupting this long antisense transcript so that dad's copy of UBE3A can express. There's a rich therapeutic pipeline here. There are several companies heavily invested in this space, many of whom are sponsoring this conference today. That are targeting this paternal reactivation approach. But in addition to paternal reactivation approaches, there are additionally groups who are working towards delivering back a functional copy of UBE3A to the brain through gene replacement strategies such as AAV9-based gene therapy and other approaches. And then we have other strategies, again, thinking about what UBE3A does and where it functions, other therapeutics in development to target the downstream consequences of not having UBE3A. So this is an incredibly exciting time for the Angelman community, owing largely to this understanding of the molecular mechanisms of Angelman syndrome and what causes Angelman syndrome, we've been able to develop therapeutics that can target the root cause of Angelman syndrome and be potentially transformative. So this is a really exciting time, and I think the next 5 years are really going to be an exciting time for this community. Thank you for your attention today, and I'd be happy to take questions when we're done.